we have to keep an ear to the ground for the new developments as they come out. But testing has come a long ways, and we urge you, if there's concern about exposure, to get tested. In our previous videos on the COVID-19 virus, we discussed things like what aren't they telling us? We talked about most recently what should we be doing? And in a previous video before the last one, we talked about ending the tribalism. In that spirit, I'm hoping today's presentation will be perceived as nonpartisan. Because if anything should be nonpartisan, it should be this pandemic, and the us versus them mentality continues, and we really should be as nonpartisan as ever if we're ever going to end this pandemic. But today, the emphasis will be on testing. Now, until there is an effective treatment, and until there is an effective immunization or vaccine, it's going to be critical that people have repeated testing. Now, because the testing is imperfect, no single test is ever going to be adequate. And because people could test negative today and go out and be exposed tomorrow, no single test is ever going to be adequate. And because the different tests are less than perfect in and of themselves, and on a percentage of the time we'll talk about more in a minute, it could be wrong. Therefore, repeated testing is going to be necessary. Now, I'm monitoring with equal enthusiasm the progress with the treatments. Medications for treating the acute illness are way behind the evaluation as far as testing. And the testing is way behind where we ought to be, but at least I can report that I feel like we're honestly making progress on that front. Now, we will mention in passing to illustrate how I want to be nonpartisan. The conversations earlier about remdesivir, it has evolved into what some are arguing is the Democratic drug. And we've had conversations about hydroxychloroquine, and it has evolved into what's becoming the Republican drug. I want to mention both of them because neither one of them is worth a hoot. Okay? Now, remdesivir was designed by and for people who want to get people out of the hospital quickly. And basically, that's all it does. It shortens your hospital stay, and it has not been shown to change the likelihood of you living or dying. Similarly, hydroxychloroquine has a bias depending on which study you read based on who did the study. So we don't know if the hydroxychloroquine or the things that have been used along with it are the real reason it's shown favorable responses when it did show favorable responses. But the politics clouds our interpretation of these data, so I'm going to stay away from it only to say we don't have adequate treatment, regardless of whether you're Republican or Democratic. But we don't have adequate treatment. Therefore, identifying people who have this condition or people who've been exposed is that much more important. The good news is not everybody's going to succumb to this infection. So, accurately identifying people who are infectious is very important. Equally important is accurately identifying people who have been exposed in the remote past. And the antibody test that we're going to talk about today may be useful, and I emphasize may be useful, in identifying people who have recovered and are immune. That's not verified, but based on experience with other coronaviruses, we believe that to be true. Now let's talk about testing in general. 3 categories of tests. There's the so-called molecular tests or genetic testing, they use that term. These tests are probably the so-called gold standard. The molecular or genetic test actually measures for viral particles. This test requires a secretion from the nasopharynx or the pharynx, and the swabs are then incubated literally, and the particles from the virus are amplified, which enhances the likelihood of identifying a positive specimen. That technology requires very elaborate and sophisticated equipment, and unfortunately in this country we have an oligopoly on access to these types of testing. So it's not as available as it is good, and unfortunately we therefore have to rely more so on the other forms of testing. Now, the second category of tests would be the antibody test. That's the one we actually do here at Wise Medical Center. It's limited in that it only tests your body's response to the virus. If you've been exposed, you'll have an antibody response for most healthy people. Early on, the antibody response is so-called IgM. Later on, the response is IgG. The test that we use is simultaneously testing for both the IgM and the IgG. Now, the IgG basically takes a couple of weeks after exposure before it becomes positive. The IgM still takes 5-7 days or thereabouts, depending on what you read, before it becomes positive. So, even in asymptomatic patients, if there's been some exposure, the antibody tests are useful to say you've had some exposure. The previous category of tests, the genetic and molecular tests, require symptoms. If you're not having symptoms, it's hard to get secretions that contain the viral particles. So that's the role of the antibody test, because it's done with a finger stick, a prick, or it can be from venipuncture. But blood is used, your serum is separated by the little kit. And basically, if antibodies are present, it works kind of like a pregnancy test. It either is or it isn't positive. Basically, it's qualitative and not quantitative. So that's one of its great limitations. But assessing this particular test serially, i.e. repeating it on different occasions, may be useful in managing populations. I'm thinking the appropriateness of that test might be in settings where we want to have congregations meeting for church, or if you want to have people meeting for school, or any kinds of meetings where people are coming together. I think it'll be fruitful for, in the near future, groups to say everybody attending this meeting has been antibody tested as recently as whatever date, and therefore all of us have been tested negative. There's some reassurance in that. The genetic test, the nasal swab, is not quite practical enough yet to do that level of testing, mostly because of the delay in getting the results, not to mention the cost. But we're focusing on the tests that are available on a so-called point of service basis, meaning you can get the results while you wait, okay? So the antibody tests, of course, we've had some experience with it. So far, roughly 12 out of every 75 is the going number of positives. So we're a little higher than I expected, but not as high as some populations that I've read about. So we'll have better data as we get more experience, but that's something on an ongoing basis I'll keep you up to date with. Now, one of the tests that's gotten a lot of political and popular exposure in the press is the so-called Abbott test. It's based on an ID Now machine. And I think they pretty much backed off from doing it. The Walgreens people near us were using it. I think they quit. The reason its limitation is the false negative rate could be as high as 48%. The original reports were 15%. Abbott, who makes this test, of course, is disputing that, and the jury's still out. But bottom line is, we gotta have better tests. Now, we have had opportunities to scrutinize several tests from overseas. And the FDA was forced to grant emergency use authorization to many tests. Last I read was over 630 different tests, of which approximately 120 of them were these antibody tests, and that number is growing every time I look it up. But so the antibody tests do have a useful purpose in telling us whether you've been exposed. Its biggest limitation, it doesn't tell you whether it's safe for you to go back to work. So when a test becomes positive, especially for the IgM, we have no choice but to quarantine people for the 14 days we believe it takes for the virus to run its course. Now, by October, if not sooner, we are verbally committed to having in our practice the antigen testing. Antigen testing uses a similar technology as the genetic and molecular testing, and therefore, if positive, it will be useful in telling you you are infectious. So we're working to get that real soon, but the difference is the genetic test has the ability to amplify the viral particles, replicating them in vitro, meaning in a test tube. And therefore, if you magnify or amplify the number of particles, obviously you have a better chance of detecting a positive specimen. The antigen test uses similar technology. Its disadvantages, it doesn't do that amplification. Its advantage is you can get the results in 15 minutes. So we're studying that, and we expect to have, I won't mention the brand name yet because there's more than one we're looking at, but the antigen form of testing is something that can be a point of service test, and therefore we're interested in acquiring it. I believe that's going to be a reasonable option in an office setting. I believe because the technology is well studied, it's the same technology as they use for influenza A and B, same technology as for strep tests. So it's not like reinventing the wheel. They have to identify the antigens that are associated with the COVID-19 virus, and therefore, using the same technology, they've developed the test. So I think with a little bit of luck, that's something we will have within days to weeks, if not within a month or two. Now, who should be tested? Let's talk about that a minute. If, for example, we're going to get back to something close to so-called normal, I think groups of people, families, people attending a wedding, members of congregations of a church or a synagogue or a mosque, all those kind of folks, if they get together and arrange for testing, then they can come together with a little more peace of mind. I think it's going to be especially important for schools. Now, there's a lot of controversy about the risks of kids acquiring or transmitting infection, but the reality is they can, and fortunately they don't get as sick usually, but that's exceptions to that rule too. But I'm thinking for peace of mind, there needs to be some literally wholesale testing on a repeat basis, whether it be the antigen that tells you whether someone's infectious, or the antibody, which tells you whether people have been exposed. With some experience, I think we're going to develop protocols, and I predict that most folks who test positive will have to have more than one modality of treatment. Now, I don't know how the powers that be are going to improve the turnaround times on the PCR testing, but those so-called gold standard tests are better, no argument, but it's not reasonable to rely on a test when the turnaround time is longer than the time it takes to quarantine you to recover from the illness. So in summary, we have to keep an ear to the ground for the new developments as they come out. But testing has come a long ways, and we urge you, if there's concern about exposure, to get tested, but you need to understand the benefits and the limitations of the testing that you are received, and I'm hoping this information will allow you to be more well informed as you receive the various tests that are available. I thank you for your attention, and I hope you'll suggest topics for future editions of the Wise Medical Minute. And I always like questions via email, info@wisemedicalcenter.com, and your questions will be addressed in future recordings. Thank you for making the wise choice.
Thank you for listening to the Wise Medical Minute with Dr. Thomas Locke. Dr. Locke addresses current events as well as important medical issues using responsible, unbiased journalism approached from a medical perspective. We invite you to submit questions or comments or suggestions for future topics by email to info@wisemedicalcenter.com. Again, thank you for viewing the Wise Medical Minute.